Thanks everybody for attending. This week we are very fortunate to have Dr. Paul Spiegel as our speaker. Thank you so much for taking time out of your busy schedule. I think maybe I will just say a few words introducing you to this crowd, and if Bhakti has anything to add, I'll give you a chance, Bhakti, and then we'll get started. Dr. Spiegel is currently director of the Johns Hopkins Center for Humanitarian Health. I know a few of our faculty work with that center, and he is a professor of the practice. And I might ask you later exactly what that means at the School of Public Health in the Department of International Health. Dr. Spiegel had a extensive list of accomplishments before coming over to Hopkins. He was Deputy Director and Chief of Public Health at the United Nations High Commissioner for Refugees, and has previously worked as a medical epidemiologist in the International Emergency and Refugee Health Branch at CDC, and has worked with MSF in refugee emergencies, and has been a consultant for numerous international organizations. And I think I could go on and on probably the rest of the afternoon, but I'll cut it short there so we can hear some words from you, Dr. Spiegel. And I'll turn it over to Bhakti, unless you want to just let Paul go right to his slides.
Hey, thank you, Paul, for joining us today. You know, emergency medicine, the root of emergency medicine, global emergency medicine in our department really started with Mike Van Ruin. And, you know, prior to the Center for Humanitarian Health, there was Center for Refugee and Disaster Response, which Tom Kirsch would lovingly call Critter. So I think it made him smile. But, you know, there's been a legacy of disaster preparedness and response work within the emergency department. And, you know, Paul and his team have been really great partners. And so for those of you who are interested in this space, I think Paul would definitely welcome us again. And it's an opportunity for us to like co-create and work together, especially given, you know, with the COVID pandemic, there's a much bigger focus now on the health system gaps that migrant populations that have been exposed to conflict have really like risen to the surface, and those vulnerabilities are an opportunity as emergency physicians, which is a safety net system to support. Paul, you may also not be aware that Nico and I have been working in Afghanistan in particular for the last 20 months, supporting a team who were providing emergency and critical care across 9 states. And we're very sad when our colleagues had their livelihoods, their homes, and all the efforts ripped away from them overnight. So thank you so much for taking the time to come and talk to us today.
Sure, no, it's a pleasure. And yes, it would be wonderful. Actually, let me just turn this. It'd be wonderful if we could rejuvenate the past relationship that we had with the school, with the emergency medicine folks, because we have had, it's been up and down a little bit, but it would be wonderful to be able to work together more. And there's a wide variety of areas, including surgery and other aspects that I think we have tried to expand but haven't. So maybe I should, what do you think? Maybe I can start with just a little bit about my background, and then I was going to talk about Afghanistan because I've recently just come back from Afghanistan with WHO, but it's a, it's a small group, so I'm happy to discuss whatever you would like. So maybe just starting with me, I'm a Canadian physician, and I did a internal medicine at U of T, and then went away. Actually, in the mid of internal medicine, I went to work with MSF as a really young doctor many years ago, and then really never stopped working in humanitarian emergencies. I worked for a couple different NGOs in the field, and by far that's the most important thing that I always tell everyone is if you have the opportunity to work in the field, work with NGOs, don't go to the UN first by any means, and really take more. And it's very difficult for people. And one of the questions may be, how do you have a clinical practice and also do humanitarian emergency, respond to humanitarian emergency? But it's really difficult for clinical people, I think, to spend months and months in the field. But if in the world of humanitarian emergencies and humanitarian response, it is best to spend 6 months to a year in the field to really understand what's happening, as opposed to the smaller 2-4 weeks here or there, because it's limiting, and it's also puts a lot of pressure on the people on the ground, because they have to get you up to speed really quickly. It takes a long time, especially if you're new at this, to understand the context. And half of humanitarian response, I think, is understanding the people, the personalities, and how to be most effective as an outsider. And we're all outsiders when we come into these situations. So then I actually ended up going back to internal medicine at U of T and University of Toronto, but I wasn't happy there at all. And I knew I wanted to do humanitarian emergencies, but at that time, this was in the late 1980s, there wasn't a path, especially in Canada, to actually do humanitarian emergencies. And so luckily, one of the internal medicine faculty that I was working with at the time had just come back from Hopkins to do his MPH, and he said, I really think that's where you should probably go. So I ended up leaving the program midway, which they weren't happy about. And I went abroad with Médecins du Monde into the Rwandan genocide area. And then I actually spent a year and a half doing clinical medicine as a family doc, or as early as a GP in Russia for an American company. And that was actually so I could afford to go to Hopkins. And so I went to do my MPH at Hopkins, and then did residency here as well. And I was chief resident, did a year of teaching or so, and then CDC had a position open in their emergency. It was called then the Emergency Refugee Branch. So it's just often unplanned. But I went there for 4 years, and then was seconded by the U.S. government. Even though I'm Canadian, I was seconded from the U.S. government to the UNHCR to start their HIV program. And I think that was in 2002 in Geneva. So we did that, and then really never came back. I stayed in the UNHCR for about 15 years in various positions. 50% of the time was in the field, really responding or mostly managing emergencies, and becoming much less clinical. I really don't practice clinical medicine anymore, and haven't for many years. And it's much more of a focus on strategy, on prioritization, management of humanitarian emergencies. And I can give perhaps some examples of what I just did in Afghanistan, because it's so fresh in my mind. And so I was with HCR, as I said, for about 15 and a half years. And then just 5 and a half years ago, I guess it was 7.5 years ago, they were doing a search for a professor of practice. I'll explain what that is, Nico, and someone to come to Hopkins to sort of rejuvenate CEDAR or CRITTERS, or whatever we wish to call the Center for Refugee and Disaster Response. And so we renamed it the Center for Humanitarian Health. And professor of practice, I think there are about 6 or 7 of us. It's a relatively new position at Hopkins. Josh Sharfstein, who some of you may know, was the first one, I believe. And there are about 7 of us now, where many of us may or may not have an academic background, but we're hired because of our experience and seniority to sort of come back and try to work on more of the practice and field components. And for example, my goal at the Center for Humanitarian Health is to try to continue with research, and most of the people working there are not practitioners, but they're researchers, which is great. But it's to try to meld the two and make sure that our research doesn't stop at the peer-reviewed publication, and actually have a more of a field effect. And then the other thing, I think, with the past administration that some of us are doing, there's another professor of practice named Len Rubenstein, who is a lawyer. Previously, he was the director of Physician for Human Rights. So we get together, we do a lot of work together with CSIS, a think tank in Washington, the Center for Strategic and International Studies. And we try to use evidence that either we gather or others do, And we then try to lobby the US government, advocate for the US government to make policy changes. And so we did this big time and still are doing it at the US-Mexican border. We're currently doing it with Afghanistan and the sanctions. And so we're meeting with people on the Hill through our connections. I'm able to have data that maybe I'll show you just in a very short presentation that we're feeding to certain people in the US government that can that we work with to try to think of a rational way to advocate on both sides of the aisle to try to improve humanitarian settings.
Hey, Paul, do you mind if I just asked you to lift your, I think your mic is rubbing against something.
Yeah, I thought so. Yes. I have to keep that up.
So sorry, friend.
I left my earbuds downstairs. So here, I'll hold this. Maybe I'll just stop there for a second because I really would like this to be informal. So any questions or comments, thoughts from anyone thus far?
So I think people ask about the clinical piece, right? Like, how did it feel? Like, what was the decision around giving up clinical medicine? You know, some of the residents here may, you know, apply for the EIS fellowship, in which case it's really challenging to be able to do clinical medicine. And well, I mean, is there any regrets, or, you know, does it give you you had an advantage or a disadvantage having given up clinical medicine?
You know, there are some people that actually do this, but then don't like clinical medicine, but I wasn't one of them. I liked clinical medicine a lot, and I regret not continuing with it. On the other hand, I know that I couldn't have done what I've been doing in this field by doing half and half. And so there's a regret, but I would do the same thing again, I would say, because it was appropriate for what I wanted. I think it's very hard. There are some people, let's say, dabble in both. So particularly either surgeons or others, and many folks at Hopkins who will say, I'm going to have a career where I'm going to practice, and then I'm going to do research studies and visit for 2 to 4 weeks into the field, and then come back and then try to juggle your clinical shifts, etc. But my goal wasn't research; it was to actually respond, and that required me to be in the field for 6 months to a year or 2 years at a time. So I've spent probably about 10 years on and off in the field, and it was my first job with MSF was pretty clinical. It was almost a clinical officer, but more and more we don't need in the field, particularly in big humanitarian emergencies, except you don't need clinical people in the field because you want to be able to capacitate the nationals to be able to do most of these things. The exception may be in major earthquakes, or when ICRC or MSF sets up clinical hospitals, self-contained clinical hospitals, then it may be more and more appropriate. But I think there's been a big shift even in the last 15, 20 years towards what we call localization. It's just more towards making sure that the nationals who either provide them the skills or to try to, and many actually have the skills. I mean, the capacities in the places that we work have improved dramatically from 20 or 30 years ago. And we're also, I think, much more cognizant of the colonial attitude and other areas that we have, brought into this response. And much of humanitarian and so-called tropical medicine is really from a colonial way of responding.
Thank you. My current split is 20% clinical, and it's tricky because it's really disruptive, but I'm trying to hold on to it a little bit.
It's good to hold on. I mean, amazingly, I still pay for my medical license in Ontario and in Maryland. And I question it every year, but in the back of my mind, something's saying just keep it because you'll never get it back. But I wouldn't feel comfortable practicing right now without a lot more, doing something, being with a group and following around for a long period of time. But it's a common question, and I think it really depends on what you want to do. The other thing that I think comes up a lot is personal life versus professional life in this field, because you to do where you're spending a long time in the field, it can really take a toll on your personal life and your relationships. And so it was not unusual for UNHCR that the divorce rate was incredibly high, because you're in these stress-filled positions. You have to rotate every 4 years at UNHCR. And even in MSF and others, you're constantly moving. And so many people either kind of put off having families till they're a bit older, or things don't always work out. So that's another big, I would say, in the humanitarian field, a big something we all have to juggle. How do you try to do it? And one of the main reasons I came back to Hopkins actually was more for personal and professionals, that my daughter had graduated. She was going to come to do schooling in the US. This position was open, and it was a nice way to keep the family together. So that was a personal as opposed to professional, but they all go hand in hand. Other questions or comments before going on? Have any of you been working in the field, in what we call the field release, in any humanitarian emergencies or other areas?
I think I'll ask a quick question. I feel like many of us in emergency medicine in this group here are lovers of implementation and direct capacity building, but find ourselves stuck at a research institution that asks something a bit different from us. As someone who has really spent significant time outside of academia and in a lot of different places in the global health world, I wonder, in returning to it, do you feel like you had to change your agenda or your activities to kind of fit back in the academic box, or do you feel like you've been able to wrangle Hopkins to your will in a sense, and take it out of maybe this research and ivory tower kind of place? I'm not sure if that makes a lot of sense.
It's pretty hard to wrangle Hopkins to your will. But the nice and bad thing, I think, is the nice thing is that, in a way, as long as you bring in your own funding, you can mostly do whatever you want, as long as it's not illegal at Hopkins. So but if I'm trying to figure out a way now. I've been here 5 years, and this past year was only the first time that I really went out as an emergency response practitioner. I haven't really done that for 4 years, and I want to do that once. I want to do that once a year, because if you're teaching and researching here, I think it's really important to do that. But it was hard because I had to figure out a way for my classes to continue, as well as my projects, because we bring in, at the School of Public Health, you're likely aware, we bring in mostly 80% of our salary through grants. And so how do you do that and keep it open? So the system doesn't really allow that very well, which is problematic. Number one. But number two is, I think, for example, I had this brilliant idea that, first coming to Hopkins, that just failed miserably. And we received money from USAID. We have a READY consortium, which is a pandemic preparedness and in fragile settings. So we wanted to put together a roster. So we worked with Lauren Sauer in emergency medicine when she was there, and others. And we trained, actually. We did I can't remember how long the training was, a week training, but it never worked out because there are so many problems in Hopkins, depending on your contract. How will your health insurance, will you get paid for this? Will you not? And it's so that it doesn't really lend itself to that, because and the only way to probably do it is to get grants of some sort that are more operational in nature, where you can, for example, capacity build others in emergency departments or pre-hospital medicine, that sort of thing, of which there have been in the past, grants like that. Problem there is that it's not always sustainable. So it's good while you do it, but not necessarily sustainable.
Any other questions? And I'm thankful that a lot of our surgical colleagues here have joined as well. If not, we'd like to hear a bit about your experience in Afghanistan.
Sure. Maybe I'll share, I have a couple slides just to share a bit. And then there is, I don't know that much about it, but at Hopkins, there is a global surgery group. And there is someone on our advisory committee. Just give me a second, his name will come, who helps. He's been a surgeon working for years with ICRC and others, Jim Colby, who's working on some of this. So their global surgery is actually a really important area. And I know that when we were doing some work in Mosul on trauma points, trauma stabilization points and everything, we were having trouble finding, let's say, people at Hopkins who were working in this area. We were able to find some people. There's a, again, I'll think of her name. She's at Stanford University. And so we worked with her a little bit. But my understanding is there is at least more and more interest among some of the surgeons here at Hopkins to get more involved in this area. And I think that is an area where there is a need for the surgical skills as well as the capacity building. The key there is to try to make sure that whatever you do is appropriate to the context and particularly also to the follow-up, because we see a lot of problems. And we all know that, where they're just not able to do the proper follow-up. Okay, let me show you, let me speak a little bit about Afghanistan. Bring this up. Can you see this? Is it full screen?
It's full screen. Looks great.
Okay. So I have too many slides, so maybe I'll just do 5 or 6, and then maybe this will bring out some questions. So this was what's called GORN, which is, it's a network based at WHO, but it's for the global community, called the Global Outbreak and Alert Response Network, GORN. They primarily do epidemics, but this was actually a broader mission for me to go with WHO to Afghanistan. And for 3 out of the 5 weeks, I was acting incident manager. And I don't know if you work with, many of you must, I would imagine, but incident management systems. And so WHO has adopted an incident management system for emergencies. So when I was there, I was running the emergency component of the response for WHO. And there's a lot of issues here, so I always put this down that this represents mine, not that, because we're dealing with US sanctions and other components. So one of the big issues, so I was there from early November to mid-December. The Taliban had just taken over Afghanistan on August 15th, and security for us still remained an issue, but interestingly, not necessarily because of the Taliban, but actually more because of Islamic State, and there were a lot of bombings occurring, in particular metallic IEDs, where they attach them onto the vehicles. So here actually, which is so interesting, because we are not allowed to provide funding, we meaning the international community, due to US and UN sanctions, are not allowed to provide funding directly to the Taliban. When I was there, we cannot call them a government, but rather de facto authorities, because no one has recognized them yet. However, we went to Sarobi, for example, which is now a district outside of Kabul, and we had Taliban forces behind us as convoys behind and in front of us for protection. And so we still worked with them in many ways and relied upon them. We were able to meet with the Taliban authorities. So this was the head of the and everyone after August 15th had been replaced, from technocrats from the previous government to mullahs for the most part. And what was interesting, though, is this is the head of the he's the provincial director of Kandahar, and Kandahar is Taliban area in the south bordering Pakistan. So we met with him numerous times, and even though he was not technical, he had been the shadow provincial health director. So Taliban had a government, shadow government, and he knew a lot. He knew what was needed, where, and he was quite professional, I must say. And then this fellow here we met, was the governor of Kandahar, who was a very senior Taliban official. So we were able to meet with them, but we were not able to, we had limitations. And the big thing is in terms of planning, in terms of funding, because of sanctions, we could not provide any funding to them. So they're pre-August 15th, yes, August 15th, the health system was divided into what's called Sahat Mandi, which is basic primary health care all the way up to district hospitals. And for the last 20 years, money was coming mostly through an Afghan trust fund. US was very, had a lot of money coming to, hundreds of millions of dollars into Sahat Mandi. And it went to the Ministry of Public Health. And then from there, the ministry had, like someone like Bhakti, I think, and you said you were in Liberia, but early on in Liberia, it was the health system was outsourced to the NGOs. So there were about 10 NGOs that were taking care of all of the health in the country, and it was divided by province. And it was very interesting. And in particular, the performance management standard and operating procedures of Sahat Mandi are really well done. And these are online, but they're fantastic. And Hopkins actually years ago was one of the early people, Gilbert Burnham, David Peters, and Cyrus Engineer at Hopkins were, amongst others, were part of the third-party performance monitoring. So they helped to set the system up. And you'd have a private group that would come in. Hopkins, now it's a KIT in Netherlands and a German company that actually try to look at what is happening, and there are very clear performance indicators, and they try to assess, and there was a pay for performance component. So they were only paid if they met certain indicators. Unfortunately, as you've likely heard, there was so much corruption in Afghanistan, an extraordinary amount, which was silly for so many reasons. The US government knew about it and were feeding into it. But much of the data were skewed, were incorrect, and they found out the pay for performance had such an effect of a distorting effect. So for example, you had to have a certain amount for stockouts, you had to make sure that there was a certain amount of medications and a certain type of medications. So in order to make sure that they would never have a visit and have a stock out and therefore be deducted money at the end of the time that they're going to be paid, because it was pay for performance, they just learned to always have a stock handy that was reserved for when people came, a way to get around this. There were so many problems with Sahat Mandi, but there were some beneficial components to it. So when this is some of the issues that we talked about. And so all of this was supposed to be free. This P4P is pay for performance. But this was in Sorobi district, where there was a cholera outbreak that we were investigating. And in the hospital compound, or let's say just right outside of it perhaps, is a private pharmacy. And even with the hundreds of millions of dollars into the health system that was put in, ultimately billions over 20 years, 75 to 80% of the out-of-cost expenditure were out of pocket, were from the Afghans themselves. So what happened is that pre-August 15th, that is the Sahat Mandi that was through NGOs. The rest of the health system was non-NGO. It was paid to the Ministry of Public Health, and then all provincial hospitals, regional hospitals, and hospitals in Afghanistan, the tertiary hospitals, were paid by the Ministry of Public Health directly, and that the ministry managed it. So at August 15th, everything shut down. All money was stopped because of sanctions, and as you're aware, so there's been this division. And when I got there, everything had stopped for the first part, and then slowly, it took months, Sahat Mandi was able to restart because the World Bank and the US government said, well, this money will ultimately go to NGOs, but we're not going to give it to the ministry. So they started to give it originally to UNDP and then eventually to WHO and UNICEF in November. But anything that was above, provincial hospitals and above, still remained government run. And the sanctions were such that no one was getting any money to these hospitals. So they hadn't been paid. The salaries for healthcare workers, from cleaners to doctors, had not been paid. And there were 6 simultaneous outbreaks occurring. and everything had to be brought in. So this is for example, this is a medicine that WHO had actually flown in from their stockpile in, I think it's Dubai. Hugely expensive and not possible to do for the long run, but there was literally no medications in the country. They'd quickly been used up. We visited a bunch of these primary healthcare centers. As I said, this is Sarobi, and I was in Afghanistan in 1996, I believe it was, just 2 weeks before the Taliban took over the first time. And there are a lot of differences from when the Taliban took over the first time and this time. Women are allowed to, in the health sector, women are allowed to continue to work. They recognize that there was a need for this, and it's completely unacceptable that in many other sectors, women are not allowed to work. But we did meet a bunch of midwives and obstetricians, and this was one of them, an obstetrician who was working in the Sarobi district. This was in November, I think, yeah, and we had they had just received their first salaries in November, and they hadn't been paid since pre-August. And then they're beyond the Sahat Mandi, which everyone, UNICEF and WHO were focusing on because you had to get this basic system up and running. We had to deal, and this is mostly what I dealt with when I was there, was the non-Sahat Mandi hospitals, what to do with them. There were 6 simultaneous epidemics going on. They're still going on. COVID, obviously, polio, measles, cholera, dengue, and malaria. There were these white zones, which are previously Taliban controlled areas, which were very insecure because there was so much fighting going on. There were all these internally displaced persons. Tremendous amount of trauma care was needed. Now, when the Taliban now took over after August 15th, interestingly, the fighting reduced. It's so much calmer, and you have access to most of the country, but the road accidents dramatically increased. And then you have a lot of non-communicable diseases, mental health and psychosocial issues that need to be addressed. Maybe I'm going to stop there for a second and just see if there's questions and or comments before continuing. Just to hear from you. Anyone on the online? Any thoughts, comments?
Surprisingly quiet group. I promise Paul doesn't bite.
And
May I start?
Awkward silences. Yeah, please go ahead.
Hi, Paul. This is Amber. How are you?
Oh, Amber, good to see you.
Oh, good to see you too.
Sure.
So no longer at Hopkins, but still working in CGEC.
Where are you?
Oh, I moved to University of South Florida.
Okay.
And I'm leading their global disaster management, humanitarian relief, and homeland security concentration. So it's quite exciting here. But sticking to your talk. So Paul, you just met with the new Taliban, officials, and I know this is a very brief interaction, but do you have any sense about their commitment to the health care, and are they going to continue with the previous policies or the programs? Are they thinking about something new? And given the current sanctions on a lot of aid to them, what are the prospects that they can stop the crumbling sort of healthcare system over there?
Yeah, no, it's a good question, and it's in what I've learned is I guess also being with the UN is as a public health professional, I'm doing that and also doing diplomacy in many, many ways. And what we found is that, number one, that the Taliban, as I said, are not the same Taliban, at least currently, are not the same Taliban as they were previously. It's very difficult to say that because when you read the media reports, it's talking about all of the very bad aspects of the Taliban, which are very bad. There are reprisal killings. They haven't opened up schools for girls beyond primary. And then, so when you say, on the other hand, you don't really want, it's hard to say on the other hand, because you say, well, that's just so unacceptable. You can't deal with, you can't deal with that. But we're trying to argue, a bunch of us, that number one, in some provinces, for example, there are schools, the Taliban, local Taliban or provincial Taliban governors have decided that schools will be open. So far, it's only 3 of the provinces. Women in Kabul and other areas are actually able to walk around. They don't need to wear the hijab. They can even just wear scarves around their heads, and they're able to walk around. And as we said, women are able to continue in the healthcare field. They recognize that early on. So one of our biggest points, and we've been working, as I mentioned, advocating with the US government, is that the sanctions are so strong and are so problematic that more people will die from the sanctions than they will from the Taliban. And we wrote an op-ed in the Washington Post about this, because they're so severe right now, and people, these suffering is incredible, because it's not just the sanctions, but it's actually the lack of a functioning of a central bank and the lack of liquidity in a country where electronic transfers are very limited. So you need what are Afghanis, the money themselves, and there isn't enough there. And so that's number one, is that there's just such a big problem in the way US and Europe and others are dealing with this current situation. And there have been some changes now. There are more humanitarian exemptions, so actors can respond, and some money is coming in, but there's still a massive liquidity problem. But the Taliban, even right now, when we met with the Taliban, they said, we understand that you can't give us money directly, but fund these hospitals, because it's incredible. This infectious disease hospital, which is my last slide that I haven't yet got to, we went there, and there's these 6 outbreaks, and this is the referent infectious disease hospital. They have no meds, so anyone that comes, you have to go outside into private pharmacies to get medications. They don't have any more LPG fuel for heating for the patient room, so they were literally cutting down trees in their in their courtyard to patients, to provide patients heating. No one in the hospital had been paid before even August. So I think, we always heard different things, but it may have been from April onwards. They really have not been paid, yet they're still coming for the moment, because they have nothing else, according to them, they have nothing else to do. There's no other, the economy's at a standstill now. No jobs available, no money available, and they are hoping to eventually get retroactive pay, which may not be possible. So they're not getting money. And on top of that, we've been arguing that we need to provide money to the technocrats in the Ministry of Public Health, because surveillance systems have fallen down. I did a whole analysis of COVID hospitals and looked at the COVID data. You really one cannot know what's happening in COVID in Afghanistan right now. And you have a huge group of very well-educated MOPH staff that are now leaving. And it was the US and others that educated them over the last 20 years. And now they're going to be gone, and they're looking to get out of the country. They're looking to work with NGOs or the UN. So we'll be devastated. The ministry will be devastated and have long-term negative effects. We still have not succeeded in getting, in figuring out a way that will be acceptable to the US government to pay technocrats. And this is not just the doctors and the cleaners and everyone else, it's also teachers. Most, all public schools, teachers are considered civil servants. And at this point, we're not allowed to pay civil servants.
It seems to me that it's going to be Yemen, but on steroids. It's going to be very fast if we don't do anything. Yeah.
And yeah, I agree. And the problem is that it's almost past now. I mean, it's so serious, like Yemen, but there's not enough time to fix the central bank and to get enough money, liquid money in the Afghanis to actually do something now that's going to stop it. It is a massive humanitarian emergency as we speak. The key now is to try to get funds in changes and exemptions so that we can reduce the amount of suffering that that is already occurring. And there are many, this is part of the fun part of the job. I'm working with a sanctions expert at Human Rights Watch named John Sifanti, and I'm learning so much about sanctions because it's so complicated. But working, we have to work in a multi-sectoral, and we need to, when we advocate, we need to bring in the human rights experts, in this case, the finance and banking experts, to try to make a coherent case. And we're trying to do, but we've had some successes, whether it's us, we don't know, but there have been some changes in the US government in terms of OFAC, which is the Treasury giving licenses to allow certain banks, private banks, to operate. So WHO and UNICEF can get money in and use that private Afghan bank to give Afghanis to the people. But there are still so many problems. And then we move into the political realm where, Biden, in terms of a upcoming 2020, midterm campaign or elections, he's very concerned about what may happen. And then likely if the Democrats lose, there's going to be some major Benghazi type commissions by the Republicans. And so there's the political component too, that is important for us to understand, because even if we're public health people, this is where I work with the Center for Strategic and International Studies in Washington, because we have to understand the dynamics in order to make the best evidence-based case. But your arguments can differ, even if, with the evidence, not changing the evidence, but the arguments that you may wish to emphasize may be quite different depending on with whom you're speaking.
Yeah, Paul, it's really interesting. So from the USAID funded RISE project that we have worked on, we actually had several pots of funding, and our work is on hold since most of our teammates had to leave the country, and there's definitely not a single emergency care expert now in the country. But USAID is asking us to sit in a holding pattern. So we've had numerous meetings that I've been involved in with General Counsel to talk about how do we consolidate all the funds that JPIGO is receiving into a single project to try and decrease the number of bank transactions so that we can still provide support. One thing that this group worked on is also, we have facility-based assessments that tell us per facility, what are the actual infrastructures within the health facility. And we can only assume that those are now less existent, but it does provide some baseline data that I think is worth sharing if it can be used as an advocacy tool. And so maybe that's something that we can get to you, if it is helpful.
Paul, you're on mute. I'm not sure if you're replying to Bhakti.
Sometimes when you have your screens up, I just can't find that small little button there. Now I see it. Okay. So yes, Bhakti, this was the infectious disease hospital, but I want to show you something. Yes, so this is the COVID hospital 19. And so we did something similar, and I realize this is not on full screen. I can share. What we were finding when we were there, particularly the polio group, who is very strong in Pakistan, and WHO and UNICEF polio in Pakistan and Afghanistan. So we started to get back these functionality assessments of basic health centers, but it didn't really make sense because most of them were either functional or partially functional. But we knew that people hadn't been paid and that there were no medicines, et cetera. And so one of the problems was either how people were measuring it and or that they were not able to get there. So they were getting information, but not perhaps the correct information. So what we did was to come up, and this is by no means scientific, but when you're in the field and you have to do something quickly, you come up and you meet. So we met within WHO and UNICEF and said, what is the best way to try to measure some functionality of the COVID-19 hospitals? Because before the survey, we were getting information back that most were functional. So we looked at medical staff and doctors. We looked at availability of medicines. We had 5 critical medicines for 50 patients. In the end, it was mostly inpatient, except for paracetamol. Oxygen supply for 10 beds for 15 days. You know, we said this was the minimum. Some hospitals had way more than 15 beds, or 10 beds, but we just said this is what we'll do because this was the lowest level. Forget patients attending. We didn't use this in the end for this. And then we looked at fuel availability, and this was fuel just to heat the hospitals because we knew that it was already in December or end of November, early December. So after we did this, you know, we looked and only 3 were fully functional that met all of these criteria. 43 were partially functional. The 15 had been closed. We weren't even aware yet that these had been closed. And the rule was no one could call. They had to go there. So WHO had enough people in the field that they had to go to the hospitals and visit. So I don't know what your experience has been, Bhakti, in terms of how to measure this in such a way. Am I off now, the sharing screen?
Yeah, you are. So, you know, we had the same issues. We had like the facility level assessment tool that was developed by the World Federation of Anesthesiologists had about 128 data points. And when I first started this work with Japigo, was responsible for like using this assessment to like decide which hospitals get ventilators that were being donated by President Trump. And it was like an impossible task, right? And like what they wanted was a numerical score to be like, if you score above 50, you get a ventilator. And if you score 25, you do not. But you know what it came down to was that there's some essential functions that without having those, it doesn't matter if you have a ventilator, electricity, or energy, you cannot execute that function. So I went through the tool and then highlighted out, pulled out the questions under each category that I thought were essential foundational functions, which could be like, you know, having a person who knows how to intubate somebody, right? Like it doesn't matter how many airway tubes you have or like how many ventilators you have, but if you don't know how to put a breathing tube in, then it's useless. And then based on that, and we did this for about 13 countries and we've never published this. If anybody wants data to publish, please take it. We sat down and gave a categorization that said like, could accept a vented COVID patient right now, could not accept a vented COVID patient. But you know, Paul, if you're interested, we did, I mean, Nico, do you remember how many hospitals there were in Afghanistan? I thought our number was like 35, but it's really detailed information, like how many plug points that were, like how many plug points were, what amperage they use, do they have a backup generator? We could share the full facility level assessment with permission, once I get permission from USAID, which I'm sure I will, and also a summary report of like what, and even if like the data in Afghanistan is not essential, I think pulling together, like, how do you think of like the critical functions or the critical building blocks?
Yeah, that's more important, to be honest. Because right now everything's changing in Afghanistan. So it still would be useful, but it depends when it was done and then the situation right now. But on the other hand, I think we'll be looking future to it's more that critical thinking that you did, that we did with the COVID-19 hospitals, to say, well, what makes sense and what is, then the next thing is what is reliable in terms of doing it, you know, because people, like everywhere, they have pride. So how do you know, are you going to meet people and say, you know, can you or not intubate? Most doctors probably in the hospitals will say, yes, I can intubate. I don't know how you did.
Went to each facility to collect this data. And on many of the early calls, I used to sit there on the call and participate in the data collection. I would say for this group, right, because you and I are tangenting into like a headspace, but what's really important for this group is that more data, I don't think, is always better. Yeah. And so when you're thinking about doing facility level or health systems assessments, there's always a compromise to be had in collecting as much data as possible, to collecting data that is limited but gives you a gap analysis, to collecting data in the middle, which is like limited, feasible, but also gives you some discrete next steps of where the capacity is needed. And I think like Paul and his team, right? People like Bill Wise, this is their expertise in understanding what are the essential data elements to be able to do a meaningful health systems, health facility-based assessment.
Yeah, and the other thing I would add to that is that when I was there with WHO, it was completely operational. And so I'm less concerned about whether this COVID-19 functionality will be published or not. But it does make a difference for others, which I completely understand. So that's one of the issues too, is that sometimes what is needed in the field is much more quick and dirty and less methodologically rigorous. And that can be difficult and can be frustrating for perhaps researchers who want something much more pristine. But it may not be useful, particularly one, if it's too much data, so you can't analyze. And number two is if it's too pristine or too rigorous and it takes too long. This was done in 4 days. And originally we got back data that the people, we could tell something was wrong. So we asked them, did you visit? And they said no. So then we got them to visit, and it was a very different situation. So calling people on the phone is not the same as well, or either. Yeah. Questions, comments from anyone? Please don't be shy.
Just a comment here. A lot of these new Afghan refugees are arriving in Florida. And Florida has the nation's biggest refugee program, just FYI.
Is that for resettled refugees, or is it you relating? No, probably also with because I thought Texas had the biggest, but you're talking about also people coming over from Mexico?
So we have, a huge refugee program that caters Caribbean nations, Haiti, Cuba, as well as now we have, Syrian, Iraqi refugees, and Afghanis are just pouring in right now. A lot of them are being resettled in this region, Tampa Bay. And the thing is, most of the people that I meet and see are the ones that you're describing, the educated lot, the ones who had been doing well until Taliban took over. And now they are in the worst condition, because now, being a refugee in the US is not easy, the paperwork, and all of, the resettlement. I mean, we were organizing, like we were actually running to airport to pick them up from airport, because this is how it works. And I mean, the government actually, the state government says, yeah, they can settle here, but they don't really get involved. And a lot of them are suffering from PTSD, and so we have a number of NGOs working, especially who specialize with the victims of torture and PTSD after persecutory or war-related situations. So it is quite fascinating because now they have to get settled in Airbnbs and depend on us for transportation and to do the paperwork. So this is another complete different area of how these refugees get resettled in other places, who are just thrown out of the country. I mean, we saw those images, but they're arriving somewhere. And it's not that, they, when they board the plane, they actually arrived in Florida. They are sitting in, military bases for like months. And now one by one, the families are, being, relocated and relocated into different states and counties. And so I actually work in, so I work for the disaster preparedness in refugee populations with the Florida Department of Family and Children. And this is how we got involved in this new, and the biggest thing that we need now is Dari and Pashto translators.
Yeah. Yeah.
I mean, this is crazy. Yeah.
Just looking at the last little bit. So, and everyone just call me Paul. So what do we see as some of the most impactful roles of our faculty, and how can folks want to get engaged with the center? Okay, yeah. So the last one is easier. I think it's more, I would say, look at what we do, and on the center website, there are, I won't bring it up, I'll just show you. So we have our projects, which are under research, and you have a project map and then projects, and you'll see where we're working and all the projects that we have, and we update it every 3 to 6 months. So one is that, and then if there's anything that is interesting to you, possibly get in touch with any of the faculty. So that would be one way. Another way would be for us to work, together with everyone, Ed, Nico, and Bhakti and others, to say, are there certain areas that you'd like to work in? That would be nice as well. There's so many opportunities, and at this point, just like everyone else, right? We're always so busy, and you have to decide which projects to try to either bid for, or you get too many or you don't get enough. So, but we'd be interested, I think, in exploring areas that in the past that, or not in the past, but in the past that we may have worked on, or areas that you think as a group you'd be interested in working in. And the harder part, though, is actually Nico, I think it was Nico, yeah, his question about how to get involved, because I've been doing some media here and there, and then I've been getting, requests. How can I get involved right now in this? And sadly, for the most part, well, I guess one is to do exactly what Amber was talking about, is get involved with the Afghans that are being resettled here, because there's a huge need. But in terms of in Afghanistan itself, it's very hard right now to do anything that would be, let's say, technical. There are limited numbers of people that are able to get in there. I was delayed by 2 weeks just because of the amount of space and visas. And they're huge. It's so overwhelming right now, and their priorities are so huge that they are just trying to prioritize. So at this point, some of the best ways would be to definitely provide, if you had any interest, provide funding to agencies that are already working there, which is probably less satisfying for you, but very important. And then, possibly for those of you that are interested, to develop some of your skills and try to figure out ways to work in this area, so that when you do get the opportunity to go into these areas, you're better prepared. There is a course that we do every year, twice a year, called the HELP course, the Help Emergencies in Large Populations. It's by far the best course in my view, which is quick, meaning it's usually, I think now it's about 2 weeks. It used to be 3. It's in it's in January and July of each year. And it's a really good, I would say, it's like an introductory course. It's pretty intense. I think it's about 6 to 8 hours, 6 hours a day now. It's been online for 2 weeks, but it really allows you to understand everything from the protection to the mental health, maternal child health, et cetera, of the humanitarian emergencies. So I would also recommend doing that. And I don't know how it works with all of you in terms of credit, but we do something similar with the School of Nursing, and they're able to actually get credit for it. But it really is a wonderful introductory course to humanitarian emergencies.
Thanks, Paul. I took it when I was an MPH student. I was taught by Gil Burnham, and I loved it. And I do think a couple of our residents are planning on doing the course, and usually I reach out to Gil ahead of time and let them know who it is.
Good.
So I think this has just been great. Thank you for everything that you're doing. I'll probably suggest that Nico send you a strategic plan and our active projects, just so you're aware of what folks are doing. And then maybe we can have a conversation about some projects that we can pursue together and do some joint applications. I definitely think that, we started this conversation about clinical medicine. And one of the advantages that this group has is probably a lot of folks here are actively practicing clinical medicine. And so, there's a passion in the center for human resources for health, health worker capacitation, expansion of training such as basic emergency care. And so I think that's a very different focal area, right, compared to the systems or the health policy level, but definitely one where we can perhaps be complementary and partner.
Okay. I think the other thing, but we can take it offline, is to figure out, are there times within I don't know sufficiently how your program works, but are there times where people can take a month and do something, or, as opposed to just little bits throughout the year? That would be something interesting as well, because I think it's really important to get into the field, and more intense times, I think, are always better learning experiences than dribs and drabs.
Absolutely. And we actually have one resident who wants to focus on disaster response and regional anesthesia. So who has time over the next 3 years to take off and dedicate. So I'll put you in touch.
Interesting. I mean, just maybe the last thing just for me to say is that our center is not sufficiently strong at all in the clinical and or the surgical. So it would have to be but we have a lot of, let's say, projects or connections that are working at health systems. But for example, something's coming up, it wouldn't be probably for your group, but on looking specifically at midwives and capacity building of midwives, for example, in a it's called an equal project. But I think there could be ways, if we meet, to talk about that. And maybe one thing is every 2 weeks we have a core meeting of our center, and maybe at one point we can bring bring you all together. We can all do something together to talk about how we could do a little bit more.
Absolutely. Thank you so much for accepting the invite today.
It's a pleasure.
And Daniel's here representing the Center for Global Surgery as well. So
Hi, Dan.
you killed 2 birds with 1 stone, I felt today.
Yeah, thanks, Paul. Thanks for inviting me, Bhakti, and this has been great. I came on a little bit late, but I heard you mentioning there has previously been surgery presence in the past here, and I think a lot of those people have left, so we've been working really hard to revive it. Kent Stevens is involved, and Alex Bloom is our wonderful student who's been coordinating everything for us. So
That'd be great.
have a lot of momentum, and it would be great to work together.
Because we get a lot of requests from.
You want to talk about kind of your.
I think that was some. The other thing is we do get a bunch of either surgical residents who are, not a bunch, but a couple a year, who are doing the MPH and have a humanitarian bent. And I've been struggling a bit in terms of who to hook them up with in the school. So that'd be great if we could talk about that. There's a lot of, there seems to be more and more, understandably, big interest in trauma and other areas. And
I was one of those MPH students a while back, so.
Okay, good. Well, now you can hopefully lead it.
Trying to create things. Yes.
Okay, wonderful. Well, thanks to all of you. It's a pleasure to meet you.
Thank you, everyone. Thank you, Paul. Have a great week.